Thank you for the nice introduction, and thank you for giving me this opportunity. Today I will talk about chemo-free approach in Philadelphia positive acute lymphoblastic leukemia. We know that Philadelphia positive acute lymphoblastic leukemia is common in older patients, and this makes the treatment challenging because usually elderly patients do not tolerate chemotherapy well as younger patients. It consists of 20 to 30% of patients with acute lymphoblastic leukemia. Before the TKI era, it was a dismal prognosis with 12% only overall survival. However, after TKI and chemotherapy and transplant, it reached to the best 50% survival rate. And I will show you through this presentation that this is even better with the chemo-free approach. I will start with a question to the audience. So how many of you would transplant in first CR a young patient with Philadelphia positive ALL who had a donor and achieved complete molecular remission? How many of you would transplant them in first CR? Afi? None? 1, 2? طيب. So maybe there is no point of this talk, but we'll go ahead and see. Okay. So I will start first with the first trial from the German group, the Jemima group. Usually the German group, they pioneered the chemo-free approach back in 2005, I think, when they look at tyrosine kinase inhibitor, dasatinib plus steroid only in Philadelphia positive ALL, and they were surprised by the complete hematological remission of 97%. However, the complete molecular remission was only 18%, and definitely 50% of the patient relapsed later. So then they designed the D-ALBA trial, where they look at addition of blinatumomab to the dasatinib and steroid. And this is the design of the D-ALBA trial, where they started with steroid pre-phase, and then they gave dasatinib and steroid for 85 days as induction. And then whatever the response, they move and they give them blinatumomab 2 cycles and with dasatinib. And they look at the primary endpoint was the molecular response after 2 cycles of complete molecular response after 2 cycles of blina. Those who achieved complete molecular response, they went and they give them 3 more cycles. And of course, they give CNS prophylaxis in form of intrathecal chemotherapy, 12 cycles. They included in this phase 2 trial 63 patients, all of them newly diagnosed Philadelphia positive ALL. There was no age limit. They included up to 89 years old patients. And as I said, the primary endpoint was sustained molecular response. They observed at the previous study 98% complete response or complete hematological response. At day 85, which is end of induction, 30% of the patient had a molecular response, complete molecular response. And this increased after 2 cycles of blinatumomab to reach 60% complete molecular response. Recently, they published their long-term follow-up. At 53 months, they found that the disease-free survival was 75%, overall survival was 80%, and event-free survival was 74.6%. 93% of those who achieved complete molecular remission did not require allo stem cell transplant. And to mention here, they left the decision of allo stem cell transplant to the investigator. 24% had allo stem cell transplant in first CR. The transplant-related mortality was 12.5%. Patients with MRD negative who did not have transplant as per investigator choice and who were in CMR, they did not require transplant. They remain in CMR without transplant. This made you question whether those 24 patients really needed transplant or no. 9 patients relapsed in this study. And they look at the relapsed patients, and they found that 4 of them had I-cross zinc finger plus mutation. And those patients later acquired the T315I mutation. And we know that I-cross zinc finger plus is a lead to genomic instability and acquirement of many mutations. Also, this made you question whether if they use ponatinib or something to target T315I, maybe we could have avoided the four relapse here. Also, there was no difference between the P210 relapse and the P190 relapse. However, the duration from the time of relapse from the complete hematological remission was more in the P210. There was 4 CNS relapse, isolated CNS relapse. So they concluded that chemo-free induction and consolidation with the dasatinib and blina associated with high incidence of molecular response and survival and few toxic effects, and it was tolerable by older patients also. Then a group from Memorial Sloan Kettering Cancer Center look at the same study, but I just want to mention in the previous study, those who relapse are those who, none of those who achieved early complete molecular remission after induction relapse. Those who relapse are those who achieved complete molecular response later on. So that's why this blissful study look at introduction of blinatumomab early. Like instead of waiting till day 85, they give the blinatumomab at 6 weeks. So it's the same concept. They included patients 18 years or more, no upper limit of age. They included only 17 patients with follow-up of 11.7 months. They gave them the same steroid and dasatinib, but up to 6 weeks. And then at 6 weeks, those who are in morphological remission, they gave them blina 3 cycles. And if they went into complete molecular remission, they give 4 more cycles of blina. And the maintenance is dasatinib. The duration is left for the investigator. Also, they noticed 100% complete remission rate. 10 patients out of 17 achieved complete molecular response. 2 patients relapsed after achieving complete molecular response. 1 refused consolidation, and 1 had extramedullary relapse with again T315I mutation. And again, why they did not use ponatinib to avoid this relapse. 4 patients underwent allo stem cell transplant in first CR. One had I think, less than molecular response, and the other one and 2 patients had Icora zinc finger plus mutation. So they concluded again that addition of dasatinib early might prevent relapse and induce early molecular response. And here they came to a conclusion that using ponatinib instead of dasatinib might suppress the resistant clone. We come to the T315I mutation. The French group, the EWAL group, they studied abbreviated chemotherapy and dasatinib and steroid plus abbreviated chemotherapy in older patients with Philadelphia positive ALL. And the number of patients was big, 71 patients. 96 of them achieved complete remission. 36 patients relapsed. More than 75% of those relapsed patients had T315I mutation. So T315I mutation is the commonest mutation that causes relapse in those patients. So based on that, the Falcon trial is a phase 3 randomized trial compared abbreviated chemotherapy with imatinib plus abbreviated chemotherapy and ponatinib in newly diagnosed Philadelphia positive ALL. And the primary endpoint, surprisingly here, was MRD negative after induction, because we know that MRD negative matters after induction, after consolidation, whatever. So ponatinib ponatinib arm reached the primary endpoint. It showed more than twofold rate of MRD negativity at end of induction. Based on this trial, ponatinib and chemo was approved as first line in treatment of Philadelphia positive acute lymphoblastic leukemia. I can say it's the only TKI approved as first line. And interestingly, the safety profile was the same between the 2 groups. There was no increased vascular abnormalities in patients on ponatinib arm. Now we come to the cream of the talk. This is the MD Anderson ponatinib and blinatumomab for Philadelphia chromosome positive. This is an important study. We know that MD Anderson pioneered the study of hyper-CVAD and ponatinib in patients with Philadelphia positive acute lymphoblastic leukemia. They showed excellent results. However, the older patient did not tolerate the hyper-CVAD, so they designed this study first for patients more than 6 years. And then when they noticed that those patients have early complete molecular remission, they included also younger, all age group, patients from age 18 without upper limit of age, newly diagnosed Philadelphia positive, adequate performance, adequate liver function. They excluded those with uncontrolled cardiovascular risk factors, because of the ponatinib side effects. And they excluded CNS disease, but they included CNS leukemia. So the design of the study, they give ponatinib 30 milligram, lower than the dose that you use in CML 45, and they shift to 15 milligram once complete molecular response achieved. This is to reduce the side effect of ponatinib. Together, they give the blinatumomab to start with on day 1 in order to induce molecular response. The first cycle of blinatumomab 4 weeks, and then 2 weeks break, and then they continue with 15 milligram ponatinib plus blinatumomab, total of 5 cycles, and the maintenance was ponatinib 15 milligram, and there was no transplant in CR1 unless the patient had less than complete molecular response, or the patient had I-cross-zinc finger plus mutation to start with. They did bone marrow after cycle 1 and after cycle 2 and 5 and every 3 to 6 months. The primary endpoint was achievement of complete molecular response at 3 months by PCR, by quantitative PCR. The intrathecal chemotherapy they gave here 15 because they learned from the D-ALBA that there were many CNS relapse, so they gave patients 15 cycles, 3 per each cycle. So as I said, the primary endpoint was complete molecular response rate, and the secondary endpoint was response rate, safety measures, event-free survival, and overall survival. They included 62 patients in this study. 40% were above 60 years. They allowed patients with more than 1 cardiovascular risk factor, but they excluded those with uncontrolled risk factors like uncontrolled hypertension. The median follow-up was 17 months. 98% achieved complete response, and 1 patient had early death, and that death was in remission. That patient had a cardiac procedure and died of hypovolemic shock. 67% achieved complete molecular response after 1 cycle. And interestingly here, they did weekly PCR on peripheral blood, and they noticed that after 2 weeks only, 60% of the patient achieved complete molecular response. So this gave them a chance to even reduce the dose from 30 to 15 even after 2 weeks of induction to avoid the side effects. 84% achieved complete molecular remission at any time, and this is the best result in Philadelphia positive so far. Then they did, for 45 patients, they did NGS as well as the PCR. The primary endpoint was by PCR, but they also did NGS, and they look at the correlation between MRD by NGS and MRD by PCR. And they found that some patients, like 2 patients, had PCR MRD negative, but they were NGS positive. And 5 patients were MRD positive by PCR, but they were NGS negative. So they found that those 5 patients who were NGS positive, they did not relapse, while one of those 2 patients who was NGS positive but PCR negative, he relapsed. So that's why they suggested that we do we rely on the decision of transplant on NGS, not only on PCR. So it's better if you want not to transplant the patient to do NGS as well, and to make sure that the patient is negative by NGS as well. And this is estimated 2 years overall survival. This is really fantastic. So event-free survival rate was 89%, and the overall survival was 89%, almost 90%, and the event-free survival was 77%. 10% relapse, 7 patients actually, after a median of 21 months. 2 relapse in the bone marrow, 1 acquired E225V mutation, none acquired, of course, T315I mutation. 1 had extramedullary relapse, and 3 had CNS only relapse. And in the D-ALBA, 4 had CNS relapse. So still we have a problem of CNS relapse on those patients. And TKI did not penetrate the CSF. So they noticed that the relapse here, the CNS relapse, was mainly on patients who had white count more than 75. So they suggested also that those patients with high white count, it's not enough to give only blina and ponatinib. Maybe you need to give like high-dose methotrexate, 1 or 2 cycles, more chemotherapy for this subset of patients to avoid the CNS relapse. 1 leukemia-related death occurred in the study, and only 1 patient underwent transplant in first CR. And that patient underwent the transplant because he had persistently low level of PCR positivity. Most adverse events were grade 1 and 2, consistent with the non-toxicity profile of the 2 agents, and ponatinib was discontinued only in 2 patients because of the possible vascular side effects. So they concluded that chemo-free combination of blina and ponatinib is safe and effective in newly diagnosed Philadelphia positive with high rate of MRD negativity, and maybe there is no need for transplant in those who achieve CMR. Again, the German group, they went back and they tried the same approach of blinatumomab and ponatinib, and they compared it retrospectively with the D-ALBA trial of dasatinib and blinatumomab. Here, for the ponatinib group, they included 88. Remember, in the D-ALBA, they were 60 patients. They induce them, again, they give the blinatumomab late, not early, same like the D-ALBA design, but they reduce the induction period to 70 days. And they give the ponatinib 45 to 30, and they reduce it to 15 once remission achieved. Instead of 12 IT, they gave here 15 triple IT to avoid the CNS relapse. And transplant in CR1 was not left for the investigator as before. It was only for MRD positive or Icor zinc finger plus mutation. And at a median follow-up of 4 months, which is short duration, they found that 95% achieved complete remission in both arms, the dasatinib and ponatinib. 1 patient relapsed in this period from the ponatinib arm, while 3 patients relapsed on the same period in the D-ALBA protocol. 5 patients went to transplant here, 24 here. The complete molecular response after induction was higher in the ponatinib arm, 27% versus 10% in the dasatinib arm. However, the overall molecular response did not differ between the two groups. But remember, those who achieved early molecular response did not relapse, but those who achieve late relapse, so maybe this will prevent relapse. So this is what they postulate, possibly early MR and less risk of relapse than dasatinib, blinatumomab. Can we go without blinatumomab, chemo-free without blinatumomab? Our colleague in China, they published this poster in last ASH, olverembatinib combined with venetoclax and reduced intensity chemotherapy. Olverembatinib, if I pronounce it right, is a new TKI, tyrosine kinase, that is potent again as a T315I. It's FDA approved in China. I'm not sure about other areas. So they combine it with venetoclax and vincristine steroid. So it's a single phase 2 arm. They included 31 patients, age more than 14, echo adequate. Median follow-up was 5.8 months, short duration. The primary endpoint was complete molecular remission at 3 months, and it was defined as undetectable BCR-able transcript by using RT-PCR method at sensitivity of 0.001. And the major molecular response was defined as more than 3 log reduction of PCR-able. So this is the design of their chemo. They gave venetoclax 100 milligram. They ramped it up to 400 milligram for 28 days. And they gave olverembatinib 40 milligram daily for 1 month. This is in cycle 1. And steroid was given for the whole month and tapered after on day 15 down. And in the cycle 2 and 3, they gave venetoclax and steroid for 1 week only. And they continue all through with the olverembatinib. And then this is the initial result. They noticed that at the end of cycle 1, this is the end of cycle 1, the complete molecular response was 54.8%, major molecular response 25.8%, and at 3 months of therapy, complete molecular response was 61%, and major molecular response was 32%. All patients achieved complete response at end of cycle 1. No treatment-related deaths occurred. No patient developed relapse or death. The 2 regimens were well tolerated. Most side effects, the 2 drugs, I mean, most side effects were grade 1 and 2. No patient discontinued any of the medication because of side effects. So this combination is chemo-free and immunotherapy-free, can be offered. It's safe and effective. However, it's, the ponatinib and blina is better, but this can be used when you cannot give blina for any reason. This is the last trial that I will show here without blina. There is the dasatinib and sequential CAR-T. Also, our colleague from China, they give short period of chemotherapy, dasatinib, vincristine, prednisolone for 2 weeks only. And then they give the patient CD19 CAR-T followed by CD22 CAR-T and dasatinib maintenance. So 18 patients received CD19 CAR-T after the 2 weeks of vincristine steroid. 14 of them received sequential CD22 CAR-T. After induction, the complete hematological remission was 100%, and the complete molecular remission after CD19 was 72, and then when they gave the CD22 CAR-T, it was 76. So there was no much difference between no addition of the CD22 CAR-T, I think. After a median follow-up of 13.5 months, 16 patients remained in complete hematological response. 14 patients remained in sustained complete molecular response. There was no patient received allo stem cell transplant, no grade 3 CRS or ICANS observed during CAR-T. My own opinion that this study did not add anything more than what we have already, I don't think CAR-T should be used in first line. So to conclude, from that trial, they concluded that CAR-T can be used and avoid transplant and so on. We go back to our question. I think you already answered properly. Would you transplant a patient in complete molecular response if you have a donor? No? Everybody know? طيب. So messages to take home. What's the best approach? We understand now chemo-free is the best approach regardless of the patient age. What's the best TKI? I think now from the Falcon trial, we know that ponatinib is the best TKI. Do we need to transplant in first CR? Selective patient, I think, those who had less than complete molecular remission, those who had Icros ring finger plus mutation. What's the duration of TKI? If you can give it indefinitely, yes, but at least 5 years, provided that you are monitoring the molecular response frequently. CNS relapse is still CNS relapse in all the studies is an issue. I think more ITs, and for those with high white blood count, we can give 1 or 2 cycles of high-dose methotrexate. With that, I conclude. Thank you so much.